Okay, so thank you everyone for attending. I apologize for not being able to be present physically due to unforeseen circumstances. So I was tasked to talk about arrhythmias in congenital heart disease patients. My name is Mohammed Ibrahim, and I'm an associate professor at Kuwait University Department of Pediatrics. I'm a pediatric cardiologist and electrophysiologist at Kuwait University. These are my educational platforms for those who are interested. So I was tasked a broad subject, obviously, and as you guys all know, bradyarrhythmia and tachyarrhythmias do happen frequently in congenital heart disease patients. So I will, first of all, subdivide bradyarrhythmia into sinus node dysfunction and heart block, and tachyarrhythmias into SVTs and VTs, of course, and there are multiple forms of SVTs as well. And then I will mention the typical congenital heart disease lesion that's associated with each and every arrhythmia that is mentioned. I will not discuss the management because it's of the time restrictions, and instead I will focus on each specific arrhythmia and its associated congenital heart disease lesion. So first of all, bradyarrhythmia, um, specifically for sinus node dysfunction. Um, as you guys all may know, left atrial isomerism is the most typical form of congenital heart disease that results or that predisposes patients to sinus node dysfunction. And just really briefly, in left atrial isomerism patients, there's bilateral left atria, there's polysplenia, and then often systemic and venous veins anomalies, and plus minus congenital heart disease lesions, sorry. Because there's no proper sinus node, because there's often a lack of right atrium, there's an escape atrial pacemaker cells that the patient controls the patient rhythm, and these abnormal pacemaker cells are often slower for patient age. So hence the sinus node dysfunction predisposition. And then post-operatively, patients that undergo congenital heart disease repairs, they often require atriotomy, scar, and with repeated atriotomy scars, you risk obviously sinus node injury because of the proximity of the atriotomy scar to the sinus node region. And furthermore, sinus venosus, or specifically for sinus venosus ASD repair, Fontan palliation, atrial switch palliation, there's so much suturing around the sinus node, and hence predisposes patients to sinus node dysfunction, in addition to the abnormal or diseased atrial tissue in Fontan, for example. And then even with the most recent Fontan, extracardiac Fontan, conduit type Fontan, there's still sinus node dysfunction in such patients. And this is a cartoon showing the sending mustard or atrial switch procedures, in which there is so much baffling of the SVC IVC to the left-sided atrium, and then and the pulmonary veins to the right-sided atrium, and hence there's there's extensive atrial suturing, and hence risk of sinus node disease. Moreover, for heart block, also left atrial isomerism patients are at risk of intrinsic heart block because of the disconnected AV node that might happen with such patients. In addition, LTGA patients or CCTGA or ventricular inversion, congenital heart disease patients are also at risk of being born or developing heart block without surgery because of the abnormal AV node placement. So in LTGA, there's ventricular inversion, i.e. the RV is on the left side and connected to the left atrium, and the LV is on the right side and connected to the right atrium. The systemic vessels are in place. So because of the ventricular inversion, there is often an disconnected normal inferior AV node, but there is a supplementary or another AV node that is the predominant one, that is more superior and anterior in location, with a prolonged His bundle track, so that predisposes the patient to fibrosis and heart block. Specifically, there is around 2% annual risk to develop heart block in patients with LTGA. And post-operatively, of course, when the patient undergoes left ventricular outflow tract surgery or undergoes perimembranous ventricular device, or sorry, ventricular septal defect closure, because of the proximity of the perimembranous VSD or aortic valve to the conduction system, the patient might be at risk of developing postoperative heart block around 1 to 2%, around 1 to 2% of times. Um, and um, and more specifically, Down syndrome patients with AVAC are also at risk of developing heart block post-repair for various reasons, but one being the abnormal location of on the posterior displacement of the AV node in Down syndrome patients or AVSD patients. And this is just an example of a posterior displaced AV node that for a patient that we just did. So this is the as you can see, the yellow dots represent the AV node, and which is in close proximity to the coronary sinus, atypically compared to the usual anterior location of the AV node. So furthermore, for tachyarrhythmias, obviously SVT could be as a result of accessory pathway mediated mechanism, or AVRT. And then the most common example of an accessory pathway mediated AVRT in congenital heart disease patients is Epstein's anomaly, of course, in which there's an associated accessory pathways at within the abnormal tricuspid valve region. Furthermore, it might also happen with LTGA, with epsteinoid tricuspid valves, or hypertrophic cardiomyopathy patients, or very rarely an appendage aneurysm and epicardial accessory pathway connections. So that's a cartoon describing the large cell-like anterior tricuspid valve leaflet with displaced septal tricuspid valve leaflet, and then presence of the accessory pathway. There's a patient of ours with an epicardial accessory pathway connection. And this is another patient of ours with a huge right atrial appendage aneurysm with a WW and SVT presentation. And because of the abnormal connection between the huge aneurysmal atrial appendage and the right ventricle. Because some of the congenital heart disease patients are predisposed to bradycardia, like we just said, prolonged bradycardia might predispose them to tachycardia, resulting in brady-tachy syndrome, namely when you have left atrial isomerism patients or severely diseased atrial tissue patients. And then typically the tachycardia is more like atrial tachycardia, atrial flutter, or AFib. This is an example of a patient with typical tricuspid valve flutter, annular flutter, in a patient with tetralogy and sinus node dysfunction. And then furthermore, rarely if a patient is, if the congenital heart disease anomaly is right atrial appendage, right atrial isomerism, sorry, there might be two AV nodes, and the patient might develop nodal to nodal reentry tachycardia as a mechanism of the SVT. Furthermore, post-operatively, when the patients undergo surgeries, of course, scar is formed. For example, after atriotomy scars, this is another tetralogy patient with an incisional atrial flutter around his right atriotomy scar. Or the patient undergoes ASD repair with of course suturing and scar formation in the atria, resulting in supraventricular tachycardia. Fontan patients, like we said, there is multiple suture lines, there's diseased atrial tissue, increased atrial mass, all results or predisposes patient to AFib or intra-atrial tachycardia or atrial flutters. This is the lateral tunnel Fontan patient that was presented to us with intra-atrial tachycardia. And then mustard sending patients, atrial switch patients are also at risk of intra-atrial tachycardia. This is a patient who we encountered as well recently, in which we had a patient present with flutter, in which we had to undergo ablation in the Senning or mustard baffle plus retrograde down the aorta to complete the isthmus block. And then if the patient has atrioventricular valve regurgitation or stenosis, obviously the atria is diseased, and that predisposes the patient to supraventricular tachycardia. In general, chronic cyanosis, ischemia, poor hemodynamics, large chambers, bad function are all risk factors for patients to develop SVT. In terms of VT, obviously, Epstein's anomalies, patients also, because of the normal RV right ventricle as well, they are at risk of ventricular tachycardia, or any patient with ventricular hypertrophy because of associated congenital heart disease. Furthermore, with ventriculotomy scar, for example, during transannular patch for tetralogy patient repair, or VAC closure, or if there's fibrosis scarring from poor hemodynamics, for example, these are all risk factors predisposing patients with congenital heart disease to ventricular tachycardia. And like we just said, for SVT, even for VT, cyanosis, ischemia, poor hemodynamics, bad function, and large chambers are all risk factors to develop tachycardia. This is a patient with Fontan with abnormal hemodynamics, cyanosis, and decreased function, who was having VT located at the just inferior to the outflow tract. So such patients, arrhythmia subtrays are similar to any other patients. For example, they have the usual anatomic subtrays, like, for example, tricuspid valve isthmuses, pulmonary veins, but they also have multiple scar and fibrosis, whether in the atria or ventricle. They have abnormal hemodynamics resulting in dilation and hypertrophy. They have conduction slowing. They have chronic bradycardia, predisposing them to tachycardia. I would like to end with an example. This is an adult patient who adult Fontan patient presenting with palpitations. If you see the ECG, the patient is barely tachycardic. You could argue this might be just simple sinus tachycardia, but if you look very carefully, there are 2 P waves for every QRS, suspicion, of course. And then for any adult single ventricular patient that's not bradycardic, you really want to make sure you're not missing atrial flutter. And then when you compare all the ECGs of the patient, you can see the P waves looks different, and the heart rate is a little bit slower than the current heart rate. And then if you superimpose both on top of each other, you can see there's a deflection here that was not present at baseline ECG, hence confirming your suspicion. So intra-atrial tachycardia could be very tricky. You require high index of suspicion. You have to look for P waves regardless of the rate. Sometimes the P waves are very low in amplitude due to the diseased tissue. You have to use multiple leads. You have to consider diagnostic therapeutic agents in testing and compare with all the ECGs. So in summary, preoperative risk factors are plenty, including sinus node displacement, absence, accessory pathways, pro-arrhythmic medication, rate imbalances, AV node displacements, and post-operative risk factors include sinus node injury, surgical scarring, hypertrophy, dilation, fibrosis, AV node injury, cyanosis, pressure overload, volume overload, and so forth. So in summary, adults with congenital heart disease are at risk for arrhythmias. Arrhythmias are unintended consequences of congenital heart disease surgery. And yes, we repair congenital heart disease patients, but typically they are not cured, and hence long-term follow-up is required. Thank you for your attention.